I'm Dr. Ken Jones, and I'm going to do a physical examination on this 6-week-old little boy. I want to start off here, this examination, right at the top, and I want to talk about head circumference. So oftentimes you will read the chart, and on the chart you will note that the baby has a head circumference that's very small. And if you, I want to stress the fact that if you are concerned in any way about a head circumference, you've got to do the head circumference yourself. And the same thing is true as far as the length of the baby. So first, the head circumference. Again, you take a cloth tape. I like a cloth tape. You can take a paper tape, although the paper tapes frequently are not very accurate. And you give the baby as big a head as you possibly can. And obviously, because of the molding, head circumferences in the newborn period oftentimes are not as accurate as they are at 6 weeks of age, but Liam here has a head circumference that's well within the normal range, and this is the way you do that. Now, as far as a length is concerned, and I want to make the same point as far as the length is concerned, Liam here is 6 weeks old, and he's incredibly content and happy. Oftentimes in a newborn baby, they are still in the position that they were in utero. And therefore their legs are pulled up and they're all contracted and they're screaming and they're yelling. And the nurse has had to do the measurement on her own or his own. And I will tell you that that's an almost impossible measurement to do by yourself. And the reason is that you've got to straighten out the legs, you've got to get the tape in a normal position, and then you've got to read that tape, and you've got to get the baby's head right, and it's really impossible. So measuring a baby is a two-person operation, and it's frequently even a three-person operation. And that's true for a lot of the things that you do on a newborn baby. So the way I do it is I get somebody to help me, and Tina's going to help me here, and we get his head as straight as possible. And Tina, can you hold his head, the tape down here? Good deal. You do it? I know, bud. Just hold that. Perfect. And then I pull the tape as high as I can, straighten out his leg, and his length is 57 centimeters. So I just want to stress there that those two measurements are two measurements that oftentimes are off. So I'm going to start here at the top, and we're going to talk about his fontanelles and sutures. A baby has a number of sutures and has two fontanelles that are quite obvious at this age. The sutures are a metopic suture here in the front, which is a vertical suture that comes off this end of the anterior fontanelle, which is a diamond-shaped fontanelle, and it's right here. And his is closed, which is completely normal. And then there are two sutures here, and they're called coronal sutures. Then there's a sagittal suture that goes back here to the posterior fontanelle, which is triangular shaped. And then there are two sutures down here, which are called lambdoid sutures. So the sutures, interestingly enough, are a little bit different in terms of the way they're configured, because the coronal sutures, unlike the sagittal sutures, are beveled, and so the coronal sutures slide together like that because they are beveled, and they allow the head to mold very nicely as the baby comes down the birth canal. The sagittal suture is squared off so that it does not bevel, they don't slide across each other, and they come together like that, and so frequently you can feel a ridge here, which is a function of the fact that those sutures are together, and you can feel, because one's riding higher than the other in some cases, and that's not the case with Liam either. So that's nice. So here's his anterior fontanelle. His posterior fontanelle is way back here. And as I said, there are two lambdoid sutures that come off that. Alright, now the next thing that I want to show you is his posterior parietal hair whorl, which is right here. It's to the right of the midline. And the normal position for the posterior parietal hair whorl is within 3 centimeters anterior to the posterior fontanelle and within 3 centimeters to the right or to the left of the midline. So he has one posterior parietal hair whorl. The vast majority of people, about 97%, have a single hair whorl. Close to 3% have 2 hair whorls. A very few number of people have more than 2 posterior parietal hair whorls. Nobody who is normal has no hair whorls. So the posterior parietal hair whorl is a reflection of the underlying brain at 16 to 18 weeks of development. So the way it works is that the brain during that period of time has most of its growth in a posterior fashion. So it pushes back in a dome-like fashion. And the skin at that time is pulled around that brain as it grows back. And the point of maximum stretch on that brain as it is, or the maximum point of stretch on that skin as it is pulled around the developing brain, as the brain grows back in that dome-like fashion, is the point where the hair whorl forms. Now, you also have to understand that the hair root starts to form at about 14 weeks, and the hair extrudes onto the scalp at about 16 weeks. So that's the point where the maximum stretch comes on that skin as it is pulled around the developing brain, and that's the point where the hair whorl forms. So the hair whorl is a beautiful representation of what the brain looks like around 16 to 18 weeks development. So a normal posterior parietal hair whorl, which Liam clearly has, is a reflection of a normal brain at 16 to 18 weeks of development. Now I'm going to move forward from here to the ears, and we're going to talk about the position of the ears and the configuration of the ears. And as many of you are probably aware, people are always suggesting that babies and older children have low-set ears, and I just want you to know that it's very rare for a baby or anybody to have low-set ears. Many people think when they are trying to determine whether an ear is low-set, they think that what you do is run a line through the inner canthus to the outer canthus, and then run that line around the side of the head and determine the position of the ear based on that line. But if that was the case, every baby that had upslanting palpebral fissures would have low-set ears, because that line would go up like that if the palpebral fissure was upslanting, and everything would be below the line. If a baby had downslanting palpebral fissures, the opposite would occur. Nobody would have a low-set ear. So the line that you draw is through the 2 inner canthi of the eye. They're the fixed points of the eye, and you take that line around the side of the head, and 20% of the ear should be above that line. Now I want to say something about the size of the ears as well, because they can be particularly important, particularly in terms of making a diagnosis of Down syndrome. So in fact, a small ear is probably the best and the most constant sign of Down syndrome, obviously, other than an extra chromosome 21. So the way you measure the ear, and it's important that when you start measuring things that you have a stiff ruler. Mine is metal, but you can have a plastic ruler or a non that is clear, or one that is solid in terms of its color. And when you're measuring the ear, and I'm just going to demonstrate this if I can here, you go from you make the ear as big as it can possibly be. So you go from the bottom of the earlobe to the top of the helix, and in his case, he's got pretty large ears. His ears measure 3.8 centimeters. So in the newborn period, the smallest ear in a full-term baby, and this is true in both Mexican-American babies and Caucasian babies, in which we've done these measurements, and we don't have measurements in anybody else, but in Caucasian babies and Mexican-American babies, the smallest ear size is 3.2 centimeters, and the largest ear size is, in a child with Down syndrome, is 3.4 centimeters. So there is a very slight overlap between 3.2, which is the smallest ear size in normals, and 3.4, which is the largest ear size in kids with Down syndrome. But Children with Down syndrome usually have ear size down around 3 or 3.1, and babies that don't have Down syndrome generally have ear size around 3.8, 3.9 centimeters. So this is a very, very good sign of Down syndrome. So if you think that you see a baby who has Down syndrome, the first thing you want to do is measure those ears, and if the ear size is, say, 3.6 centimeters, almost always you can forget about a diagnosis of Down syndrome. So that's the ears. Right now I want to talk about the eyes, and the intercanthal distance is a measurement that is done from the inner corner of one eye to the inner corner of another eye, so it's just a simple measurement that goes from one inner corner, or one epicanthus to the other epicanthus. So his intercanthal distance here is 2.5 or 2.8, which is completely normal, and he has a very low nasal bridge. So all babies have a low nasal bridge, but Asian babies have particularly low nasal bridges, and it's interesting that to think of the lowness of a nasal bridge as far as the baby is concerned. Because if you are a cartoonist in a newspaper or whatever, and you are trying to create an individual who is very cute and very attractive, you put their eyes far apart. And if you want to make somebody look sinister and evil, you put their eyes close together. That's sort of snake eyes. So the thing that really makes your eyes, or that you can make eyes look far apart, is if the nasal bridge is low. So what happens, babies are born with a very low nasal bridge, and it looks like their eyes are very far apart. They're not so far apart, but it makes them look far apart. And because of that, maybe not because of that, at least not because they're, as far as their mother is concerned, but one reason that that is the case is because their nasal bridge is so depressed. And then with time, as a baby grows, and then when the baby hits adolescence, the nasal bridge grows forward, and it brings their eyes together, and they clearly, at least to themselves, start to look very odd and very sinister. So babies have very low nasal bridge, and it really adds dramatically to how cute that they look. So the palpebral fissure length is another measurement that is very helpful in terms of your thinking about a newborn baby. And this is clearly the most difficult measurement that you can possibly make. So the palpebral fissure measurement is made from the inner corner of the eye to the outer corner of the eye. And so this is the way you do it. And it's particularly hard in a baby because they don't like to open their eyes and they don't listen to you. But the normal palpebral, but what you have to do is spend a lot of time. And Liam here is being very cooperative with me. And I've already figured that his palpebral fissure length is about 2 centimeters, which is really completely normal palpebral fissure length in the newborn baby. It actually goes from about 1.8 to 2.0 centimeters. And the palpebral fissure, from the standpoint of its normal development, is a dependent structure. So it depends on the optic vesicle, or the eyeball. So the eyeball is an outpouching of the frontal region of the brain. So the optic vessels come forward, and they induce the palpebral fissure. So the size of the palpebral fissure is a function of the size of the optic vesicle and the position of the optic vesicle, which is determined by the frontal area of the brain. So anything that affects the frontal area of the brain can affect the optic vesicle, make it abnormal in terms of where it is going to go out and induce the overlying ectoderm to form a palpebral fissure. And it also is critical because if it's smaller than it should be, it induces a smaller palpebral fissure. So again, like the hair whorl, the palpebral fissure can be extraordinarily helpful to you in terms of giving you an idea what early brain development was like. So the philtrum also can be very important to you in giving you some idea about what the underlying brain looks like. And the philtrum is the area from the base of the columella, which is right here, to the vermilion border, which is the top of the vermilion border, which is right there. And this area, as you can see here on Liam, has these two vertical ridges. So those two vertical ridges are completely normal structures, and Liam has a completely normal looking philtrum. The important thing for you to recognize is that that area of the face comes from the medial nasal processes of the developing frontal area of the brain. So the nasal processes are the area where the nasal pits are going to be. Nasal pits start around the side of the head, and the medial processes, or the medial area of those nasal pits, is the area of the frontal area of the brain where the philtrum, this area, comes from. So as time goes on during facial development, those nasal pits come forward like this, and they obviously reach almost to the midline, and that area that is going to make up the philtrum is pulled around with those nasal pits. So if there has been an insult to that area of the developing brain, either some kind of a structural or an environmental or a genetic insult to that area of the medial nasal pits, then there can be a problem with development of that philtrum, and the problem that generally speaking develops is that there is a lack of those vertical ridges, so that the philtrum is completely smooth. And that's the case in a number of structural defects like holoprosencephaly, where there's a defect in early brain development in the frontal area. It occurs with the fetal alcohol syndrome, and one of the major areas that alcohol affects is the frontal area of the developing brain. And so by virtue of having that insult to the medial nasal processes, the philtrum is very smooth in both of those disorders. Now I want to talk about the hands. And the hands can also be very helpful in telling you something about early brain development. So if you straighten out the hands, and obviously in a baby they have their hands clenched, so it can be difficult to straighten a baby's fingers, and one of the tricks in terms of doing that is to flex the baby's wrist, because if you have the baby's hands like this and you try to extend, it's much harder than if you have the baby's hand like that. So if you straighten the hand, what you, first of all, looking at the palm, he's got 3 creases on his palm. So he's got a thenar crease, which is that, and then he's got a proximal and a distal palmar crease. So that's completely normal. Those creases are due to movement of the fetal hand between 8 and 10 weeks gestation. So again, we're talking about brain development, because if a child has a problem in early brain development, they're not moving adequately, and if they don't move adequately, they frequently have abnormalities of their crease pattern. You know, a mother, when you ask her when the baby started moving, she will tell you generally at about, she started feeling the baby at about 18 to 20 weeks gestation. However, a baby starts moving long before that, and the baby starts moving by 8 to 10 weeks at least, and those crease patterns are a function of that. So the thenar crease is a function of that movement of the thumb. And the proximal and distal palmar creases are a function of the fact that our palm is not completely square. So if our palm was, well, our palm folds in this direction and it folds in that direction by virtue of the fact that the 4th and 5th metacarpal bones are shorter than the 2nd and the 3rd carpal bones. So by virtue of that, the hand folds like this, and you get these 2 palmar creases. So in Down syndrome, babies have a single crease across here in about 40% of the cases, and the reason for that is that the 4th and 5th metacarpal is the same length as the 2nd and 3rd metacarpal, and by virtue of that the palm is square, and by virtue of that when the palm starts to fold at 8 to 10 weeks, it folds like a door on a hinge, and you get a single crease across here. So that's the palmar creases, and then the interphalangeal creases also can be very helpful. And so you can see that he has a proximal and a distal interphalangeal crease on each one of his fingers, and that's completely normal. And again, the creases in the interphalangeal region can be very helpful in terms of the same thing, fetal activity. So if you have a baby who has contractures of the fingers, and that baby has crease abnormalities on the fingers, that tells you that those flexion deformities of the fingers occurred prior to 8 weeks gestation, prior to the time that the crease pattern formed. So it can give you not only an indication that there was a problem in fetal activity early on, but it can also give you an idea when that problem started. So if you see a baby with contractures of the fingers and missing creases on the fingers, that's called camptodactyly, C-A-M-P-T-O-D-A-C-T-Y-L-Y. And if you see camptodactyly, that tells you that it doesn't give you a diagnosis, but it tells you that that baby was not moving its fingers, or his or her fingers, prior to 8 to 10 weeks gestation. And it could be due to a neurologic problem, it could be due to a tendon problem, it could be due to a bony problem, but it behooves you when you see that to say, all right, this baby had a problem with early movement, and the question is why. Next we're going to look at Liam's chest and just look at a couple things here on his chest, actually just one thing on his chest. And I want to talk to you about a structure that you probably don't think about very much, and you probably don't think about it particularly with respect to measuring it. And so what I want to talk about is the sternum. So the sternum is measured from the sternal notch up here to the tip of the xiphoid down here. And the only thing to be aware of in a baby is the length of the sternum. So the sternum should be equal to 1/3 of the distance from the sternal notch to the symphysis pubis, or more than that. So you measure it by, we'll just slip this, undo this here just a little. The symphysis pubis on a baby is beautifully marked by a horizontal crease. So the top of the symphysis pubis is right there. So let me just take my tape measure here, and we'll go right from the top. Thanks, where's that, Tina? Thanks. We'll go right from the top of the symphysis pubis, or right from the top of the sternal notch to this horizontal crease here, and that's at 22 centimeters. And then his sternum is 7.5 centimeters. So that's quite a bit greater than 1/3 of the distance from the sternal notch to the symphysis pubis. So his sternum is a perfectly normal length. Let me just get him back together here. Completely normal length. And the reason I bring that up is because it is a very nice diagnostic sign of trisomy 18 syndrome. It's a syndrome that we in pediatrics in the newborn period don't see very frequently anymore because most of those babies are diagnosed prenatally, but it's something always to keep in mind. Now, I just want to mention one other thing before we finish with Liam, and that is looking at the palate. There are many people that will tell you that you can determine whether a baby has a cleft palate by sticking their finger down their throat. And I can't tell you how wrong that is. You will miss a substantial number of babies' cleft palate, and definitely a bifid uvula if you do not stick a tongue blade down there and get a light and look. And I'm sorry, Liam, I'm going to have to do that just to demonstrate this, but I've kept it to the last, and that's an important thing always to do, because he's not going to like this. So you really, a baby's throat is such that you really have to get it down there and all the way back, and you can see, or at least I could see very nicely, that his palate is completely intact, as is his uvula. So you can say without any question that this baby does not have a cleft palate or a bifid uvula. So this concludes what I'm going to go over as far as a physical exam today. Obviously, there are a number of other things that are critically important to do when you do a physical exam, like listen to the chest and check for hip dislocation and a variety of things like that. But what I thought I would like to do is to go over some things that represent minor malformations, and particularly those minor malformations that you can see on an external examination of the baby that can give you an idea about brain development, because that clearly is the thing that's most important to document or try to document in the newborn period as early as you can. And so if you pick up some sign here that is altered that I've been showing you today, that's a baby that needs to go under the microscope so that you can follow that baby carefully from the standpoint of his neurologic and intellectual and cognitive development. So thanks a lot.